present is Dr. Media Alias, obstetrician and gynecologist. She's a fellow of the Royal College of Obstetrician and Gynecologist and is known for holistic patient-focused approach to women's health. Dr. Alias consultant at multiple sites across Melbourne's northern and western suburb. Media provides comprehensive care for a wide range of women's health conditions, including obstetrics, antenatal and postnatal care, supporting expectant families through stages of pregnancy. She's a gynecologist and she offers advanced laparoscopic surgery, keyhole surgery. She manages menstrual disturbance and PCOS, pelvic pain, endometriosis, and pelvic organ prolapse, abnormal pap smears, and colposcopy. And she's managing menopause and HRT. The stage is yours, Media.
Thank you very much, Dr. Nian. And my talk is about cervical cancer screening. As we've mentioned, the screening program is for us to detect and prevent cancer before it happens, and cervical cancer is one of the most important cancers when it comes into that. Why cervical cancer? Because it is the 14th most common cause of cancer for women and people with cervix in Australia. And at the moment, about over 946 cases has been diagnosed in 2025 in Australia. That is 1 in 190 cases, or about 0.5% by the age of 85. About more than 70% of those women with a cervical cancer, they have not had screening or they have been not screened regularly. And this is an ongoing battle. The role of the HPV virus or human papilloma virus in cervical cancer has a big, big impact because 12 carcinogenic types to human have been found. And from those type, HPV 16 and 18 are considered to be the most oncogenic types, being responsible for more than 70% of cervical cancers worldwide. HPV is the common virus that affects the genital tract. More than 80% of people contract the virus at some stage of their life. So it's very, very, very common. And I usually start by saying that to the patient because they all walk in with a HPV result positive and they all feel like they have cancer. So that is not true. The other risk factors, as we know, is smoking, weakened immune system, and long-term use of oral contraceptive pills, and that is mainly not because of the pill effect, it's because of not using the barrier contraception method. Therefore, more exposure to HPV. So the objectives of today's talk will be to look at the current cervical cancer screening program in Australia and understand the new guidelines of 2025 updates, and clarify the role of the general practitioners in regard to screening and follow-up. And by doing that, hopefully we can improve patients' participation and detection. So if we look at the National Cervical Cancer Screening Program, that has replaced the old pap smear test since 2017. And HPV virus came into role as a primary test for detection. The target group is from the age of 25 to 74 years of age after the commencement of sexual intercourse. And the screening interval is every 5 years, which is very safe to do. Why cervical cancer screening test? Because it detects human papilloma virus, which is the cause of most cervical cancer, as mentioned earlier. It is more sensitive than cytology and enable us to detect earlier intervention and support the goal of Australia, which is aiming to eliminate cervical cancer altogether by 2035. Anatomically, if we look at the cervix, this is the start or the entry to the uterus. More than 90% of cervical cancers, they start at the squamous cells at that junction, and about 10% are columnar type or glandular type. And the changes happens in that area in between, which is our squamous-columnar junction. Who is eligible for the cervical cancer screening? All women or people with cervix aged 25 to 74 who have had any type of sexual contact, and that is skin-to-skin, genital skin contact. because the use of condoms, as mentioned, doesn't give us full protection, and there is not full coverage of the genital skin area. If the person is gay, lesbian, bisexual, transgender, or straight, they still require screening. If they have had HPV vaccination or not, because there is no full protection against all type of HPV viruses. And they are no longer sexually active. If they are postmenopausal, they have been with one sexual partner throughout their life, and we get that question a lot, they still need to have screening. And they have had children, or they are currently pregnant. Very, very important. Pregnancy is not a contraindication for HPV screening. Who is not eligible? The patient who display any symptom that might be as a result of changes in the cervix or cervical cancer, like unexplained postcoital bleeding, abnormal looking cervix on examination, and intramenstrual or persistent postcoital bleeding, postmenopausal bleeding, unexplained or persistent vaginal discharge, and post-treatment of adenocarcinoma in situ, and if the patient has been exposed to a DAS in utero. So in this group of patients altogether, they still can have this test, but not as a screening. They will have it as one of our method of detection and diagnosis of their symptoms. What's new in 2025 update is the expansion of the self-collection access. Now the patient can have it in different forms, even if they have had treatment, and that replaced the test of cure pathway that we used to call it. The whole pathway is being simplified and have much simpler protocol to follow, and then we'll go through some of the changes to the management of abnormalities. The main key update, number one, is the self-collection test. Simple, easy, affordable, and the patient can have it within a few minutes with very minimal discomfort. And that's available now for all patients. It's a simple vaginal swab, patient collected, and it is, when we look at the accuracy, it's very comparable accuracy to clinician collected sample. It improves access and participation and really overcomes lots of barriers that patients might have. The role of the general practitioners, it's really to take that opportunistic approach and mention it to the patient when they present with any other form of symptoms not related to their screening test, and we can mention at the end, by the way, have you had an updated screening test? And we offer it as a routine test, and it's especially useful in under-screened non-English speaking patients. The second key update has been on the test of cure when the patient have had high-grade squamous intraepithelial lesion treatments. Used to be a complex cytology and HPV pathway, and they had to have two tests with negative on both cytology and HPV, but now it is simplified. They can only have annual HPV test, and it can be self-collected and require 2 consecutive negative test results. Then they can go back to routine 5-yearly screening. The third update is in the post-treatment surveillance of adenocarcinoma in situ. They used to have annual screening yearly indefinitely throughout their life. Now it is yearly screening for 3 years. If they are negative for the 3 years, then they can go to 3 yearly, and if they are negative for 5 years, then they can have that as their 3 yearly screening as an ongoing for the rest of their life. For patients with intermediate risk, where they have HPV non-16-18, now we have more conservative approach. It used to be 2 years and then refer to a colposcopy. Now we can actually have patient by patient and certification, and as long as they are under the age of 50, they're non-indigenous background, they don't have symptoms, and they have had their regular screening, then we can actually have more conservative approach and offer the third HPV testing. And that will delay the colposcopy and the discomfort from that. But it's very important to escalate from HPV testing before, as we can see, any changes in their cytology. And from that, the screening pathway is now simplified. So it's only HPV testing. If negative, return in 5 years' time. And if HPV is detected, there will be a reflex cytology on the result. And we based our management on the risk stratification. Special population like Aboriginal and Torres Strait Islander patients, or endoscreen or never screened patient, or post-hysterectomy patient, immunocompromised and pregnancy, they all have their special pathway, and that is by more frequent screening, which is usually every 1 to 3 years, and mostly every 3 years for those patients. The responsibility of our general practitioners is to identify these eligible patients, offer self-collection option as a routine, interpret the results correctly, and ensure follow-up and compliance. And really need to encourage participation. And as we know, most of our women come in and they do not want to participate because of embarrassment, cultural barriers, access issues, misunderstanding or lack of awareness, and self-collection, sample, and simple discussion really improves on all of these factors. So the key message is now that screening is every 5 years, very safe, which is what the patient gets scared of. HPV is very common and usually transient, so it can be cured. And early detection prevents cancer. Self-collection is easy and is effective. And the impact of the screening program really has a big impact on reducing the incidence of cervical cancer. Majority of cases, remember that, happens in endoscreen or never screened individuals. Thank you.